Welcome to Alive and Well, your healthy living podcast for movement professionals and for the professionally curious. We have Dr. Stuart McGill with us today. He is out of Waterloo, Canada. Are you in Waterloo today?
No, I'm not. I retired 3 years ago from the university.
Okay.
So I retired to a town called Gravenhurst, about 3 hours north of the university.
Oh,
And
great.
I have a little clinic here.
Oh, fantastic.
Yeah.
Fantastic. Dr. Stuart McGill's website is backfitpro.com if you want to go there while we're speaking today and check out a little bit more than we're talking about. He is Professor Emeritus from the University of Waterloo in Waterloo, Ontario, Canada, where he was a professor for 30 years. His advice is sought by governments, corporations, legal experts, medical groups, and elite athletes. He has over 240 peer-reviewed scientific journal papers, several textbooks, international awards, and to back up on the textbooks, we have Low Back Disorders behind us. We have The Back Mechanic and Ultimate Back Fitness and The Gift of Injury. Welcome, Dr. McGill.
Well, thank you very much, Karina. I'm really looking forward to this for several reasons, but those will become apparent as we go through this.
Great. And you are a doctor of kinesiology, correct?
Well, my PhD was in spine biomechanics in the Department of Kinesiology, actually, yes.
Okay. And then after graduating with a PhD, did you begin teaching directly, or what were you doing immediately after that?
I did become what was called a research assistant professor, and then within a year I was an assistant professor and started with my laboratories and whatnot. So over the 30 some odd years, we had two laboratories. One was an in vitro laboratory where we took cadaveric spines and we created the injuries in them. So we got a one-to-one match between what very specific tissue damage emerged from a very specific loading scenario. And then what was the cascade? In other words, disc bulges, for example, quite often start with another insult farther upstream. For example, an overload of compression might crack an end plate at the micro level and then allow some of the collagen strands that form the annulus to delaminate a little bit. Anyway, we documented those cascades. And then we had the second lab, which was the in vivo lab, where we measured real people. And basically, we constructed their virtual spine from stacking their CTs or MR scans. We would have their spine in the computer, but it was very dynamic in that as the person moved, we would monitor their three-dimensional movement. And then with EMG, we would measure their muscles activating, and then we would activate their virtual muscles. As they moved passively, we would then assign stress strain curves to the disc, the various ligaments, and that kind of thing. And then the third part of the whole scientific effort was I started a clinic just over 20 years ago. It was an experimental clinic. And I'm probably talking too much at this point.
No, not at all.
But it was very unique in that our first appointments were 2 hours long. And my traditionally trained colleagues would say, 2 hours for an appointment, what are you going to do? And but I said, I must do that because, first of all, we have to listen to the patient's story. What are the impediments that cause them to systematically fail in the previous 12 clinical experiences they had before they got here? We had to understand those. And then to listen to their pain patterns. We would then do provocative testing to provoke the pain so we knew very precisely what caused their pain. Sometimes this was very mysterious to the patient. They said, well, we never really had an idea of what caused our pain, but we certainly do now. And then the next part of it was to come up with the antidote? Can we get them to move and do their tasks in a way that doesn't trigger the offensive trigger? And then build a program that fits their particular goals and injury history and age and all the rest of it. So that was what we did, and part and parcel of all of that, of course, you teach the graduate students that are putting the horsepower in the scientific operation, and I taught some undergraduate courses along the way as well. But that's it in a nutshell.
And so you're still doing something similar at your clinic there?
Well, patients fly in from around the world, and they get a very thorough assessment, and most of the time, a really thorough understanding of what their pain mechanism is, together with a strategy to deal with it. Now, I know you are a scoliosis expert. I do not call myself a scoliosis expert, although I have a few opinions and a little bit of experience with it. But I certainly wouldn't consider myself a frontline scoliosis. I'm aware of certainly what you do, and I'm sure we're going to have some discussions about this.
Yeah. Well, you'll be happy to know that you helped me on my own path tremendously before investigating the scoliosis specific route. So having back pain since the age of about 10 years old, so not my entire life, fortunately, it was always kind of a mystery to me what was going on and what was the proper care. And having had a professional dance career, and having had back pain take me out of that career, it was your books are infinitely interesting to me. And I do remember buying your books the first time. And one of the parts that intrigued me before, beginning from the beginning, was the discussion you have on silly stretches in the book, those stretches where you might hug your knees to your chest, or maybe hang out in child's pose for a bit. And can you explain to us why those stretches might feel good for a moment, but ultimately aren't the best choice?
Yes, just let me give a framework and a context to that. So I think the seminal issue here is, are we discussing a concept for a group of back pain people or for an individual? So when you write a book, by the way, when I wrote Back Mechanic, the original publishers said, you must have in the title, Fix Your Back in 5 Easy Steps. And I said, I'm not writing that because it's not true. There's no such thing as general back pain, just like there's no such thing as non-specific leg pain. It's all very specific, and people have to be subcategorized into categories that they will do well with a specific type of approach. But for the next group, that approach will be very inappropriate and will probably make them worse. So when you write a book, what I did with Back Mechanic was to guide the reader through a self-assessment of their pain to start to get some subcategorization. So it might be that bending backwards causes their pain. So let's take a typical pattern within the dance community, since that's your background. It's quite prevalent to have extensor-driven pain. So if that subgroup was identified that way, I could write a more definitive approach to say, here are some strategies to avoid extension, let your pain wind down, let the tissues that are causing the pain desensitize and adapt, and we'll go from there. So now I can answer your question about the silly stretches. I wrote Back Mechanic primarily for the readers between 20 and 55 years of age. The dominant pain mechanism for that demographic will be discogenic, so disc bulges and a little bit of loss of disc height and that kind of thing. Many of those people have been told pull your knees to your chest, stretch your hamstrings, and that kind of thing. Well, since they fell into a discogenic category, it's paradoxical. Pulling your knees to your chest fires off a stretch reflex. In most people, that gives a little bit of a neurological jolly, or really it's an analgesic for about 15 or 20 minutes. So they get the perception that what they just did was good. It was pain relieving. But the problem with it is the disc has now been further sensitized so that you now need to stretch again and again and again, and it's a never-ending battle. So I call them, just for that particular subcategory, rather silly. Now, we follow up with every patient that we see, Karina. We know exactly the score. Those who fall into that flexion triggered discogenic category, when we advise them to stop flexion stretching and pulling their knees to their chest, they say, oh, well, I feel odd for 2 or 3 days because I'm used to feeding the stretch reflex. However, then my pain started to desensitize. So that's the story, because you write a book for a group. But now I have to play the other side of the coin and the argument, and that is every person that comes here gets a personal assessment, and we figure out with precision what their pain triggers are. And it may very well be, say we did have a person who came in with a cofactor of a structural deviation like spondylolisthesis, like scoliosis. Now, of course, I'm a big believer. I've measured the various Schroth techniques, Gabriella Schroth, for a scoliosis person. I may very well try and hold down a rib cage and stretch and open up the deficit side, and there is some efficacious data on that. But you will know with the person in front of you, if you follow up, have you helped them or not? So is the stretch silly for them? Absolutely not. So anyway, there's the broad context when you write a book versus you're dealing with a person who is sitting in front of you.
Yeah. Yeah, I understand what you're saying, really paying attention. And certainly when I started following your work, and the DVDs that I got from you early on, it was very clear that that was what you were about. You were about, the case study of the person in front of you. And certainly that's very, very rewarding as someone who's also trying to help people. To switch gears slightly, your advice is sought by governments, corporations, legal experts, medical groups. Can you give us an example of where the government or a corporation, someone might have come in and you might have made some changes, some large changes globally for the organization?
Yeah, well, there's many examples that I can think of. In fact, I have a call at 5 o'clock tonight, a conference call with a legal team who is defending a group who are allegedly making some false claims about some devices that they use for the treatment of back. So there might be an example from just my workload today. But I'm thinking of different manufacturing facilities where they would have quite a high price tag on their back compensation for, say, the previous 3 years. Mm-hmm. And they'll say, well, let's put in the program, and we call it job coaching. So I can give you an example from quite a prominent company that did what we call job coaching based on our scientific principles. So they hired a public health nurse plus a job coach trained in our system. That cost about $250,000, their salaries and the office and outfitting it and whatnot for the 1 year. Over the next year, the company saved $1.25 million in its low back compensation payouts compared to the historical precedent of the previous 3 years. So what did the nurse and the job coach do? When a factory worker complained or presented with back pain that was disabling to them, it was affecting their work, it might have even resulted in lost time, and that's what is compensable and the expense to the company. First of all, a ergonomic analysis would be done on their workplace. Is there something that you can do in designing the job to fit them a little bit better and reduce some of the physical stressors? It might involve some work organization, changing the rest breaks or whatever was specific to them. And then they did a little bit of an assessment on that individual and how they moved. And quite often, it's the way that they are moving or the physicality of their body that is predisposing them to the pain. So not only are you looking at the job, you're now looking at the person. So an example I could give you there, we measured, this is a different company now, and it was fellows who chromed car bumpers. The car bumpers weighed about 70 pounds and they lifted car bumpers all day long. Interestingly enough, when we studied the group all doing the same job, only some of them had disabling back pain and lost time. Others never did. Now, do you think it was the ones with the stronger backs that were bulletproof, who didn't get back injury? I'll just ask you that question.
Yeah, it would seem that the stronger back would be injury proof.
No, it was exactly the opposite. It was the ones with the stronger backs who had more injury, but there was more to the story. Then when you separate out the trait of muscle endurance from muscle strength, muscle endurance turned out to be much more important. And what we found the pathway was those who were strong and didn't have sufficient endurance would lift the car bumpers with good form for a little bit, but then they got fatigued and they started to use their backs more and their hips less. Now they stressed their backs and crossed the biological tipping point. So it was actually more protective to have not as much strength, but to have more endurance, because that meant you moved well in a way not to build stress concentration. So, you know, I know there's a trend that you may have heard now that some therapists are saying posture doesn't matter and these kinds of things. Well, it matters a lot when you have to repeatedly lift loads or perform a demanding job like that. So that might be an example of going back to it was actually a tire manufacturing facility where I gave the example of job coaching. So there's an example of how I might
very interesting
expertise, or we might have thinking along the same lines. I can think of an Olympic program for another country in the world where we really reduced their back injury rates. And then we measured what athletes, all doing the same sport, were more resilient to the training. And it turned out they, if they had sufficient back muscle endurance, but not a tremendous amount, we used the keyword sufficient. There was an envelope. Just have sufficient endurance. And then we made a statistical cut point on that based on measuring all of the athletes. So we found out how much endurance was actually optimal for maximal training resilience and performance. So there might be another example going from a factory to an Olympic elite sport program.
Yeah, interesting. It's really, really interesting. And when we, let me go through, I have so many questions here, and I'm not sure if this is too general a question, but bear with me. You know, we have so many people come in, and of course, I give them the best answer I can, but what do you say and what might be the culprit when you have someone walk in and they grab their low back, they wipe their hands basically across the thoracolumbar fascia, and they say, it just aches here. As a clinician, what can I tell them is going on, and what is specifically going on when it seems that whole tissue itself is just inflamed?
Well, all I can do is describe what we would do.
Mm-hmm.
Yeah. I would talk to them and try and understand. In the interview, I'm doing pattern recognition. So I'm looking for different patterns. Is it worse when they get out of bed in the morning? Is it associated with a specific activity? Is going for a walk relieving or exacerbating? Then I want to know a little bit about their home life. What clinicians have they been to before, and what previous treatments have they had that they've failed with? Because I don't see frontline back pain people. I only see the failures. So they've already been to 10 or 12 clinicians, and they've been conditioned to fail. But then I find out that nowhere along the line have they had a decent assessment. So consuming what I've just heard, I then bring them down to this room here, which you see. There's a patient table, and I've got a lot of gear around where I will assess their pain. So I do provocative testing. I'll just have them sit on a chair just to begin, and I'll say, pull up on the chair 20 pounds per side, or 8 kilos per side. And does that increase or decrease or change your pain in any way? Let's say they say no. Okay, then I'll say, slouch. Not with your head and neck, just with your spine like this.
Mm-hmm.
Oh, yeah, that causes my right foot to go numb. That didn't change my back pain. Then I say, good. Oh, yeah, that makes my toe go numb. Oh, there's my back pain right there. So I just identified, as we drifted the spinal cord, they had a friction that was causing their back pain. So we've already determined that their foot pain is 100% posture driven, and we'll sort that out. Is it a sciatic root, or is it a bulge at either L4 or L5, which are the two roots on that would serve the foot and give that symptom? Or is it that they are moving and there's a friction, say, at T9 because of some existing damage? And then at the end, I'll go to the MRIs or the CTs if the person has brought some imaging, and I know there is going to be some friction causing mechanism in their lower thoracic spine, because that's what the assessment showed me. Now, when I go and look at the MR, I can say, aha, there it is. You've got an open fissured dynamic disc bulge at T9, or you had a compression fracture at T9. You fell off a skateboard, or you fell down the stairs, or whatever it happened to be. So it really locks us on as to the feature that we're seeing on the MRI. It may be painful or it may be not. But if you don't have the context of previously assessing the person, you have no idea whether that's a pain generator or not. But if you look at the MRIs afterwards, now the magic unfolds. And this is a huge problem with medical practice broadly, in that the radiologist who reads the MRs or the CTs never sees the patient. So they have no context for the features that they're seeing. And then they publish papers, oh, medical imaging is not helpful for back pain. And I just have to shake my head, because it's incredibly helpful if you do the assessment of the person first, and you have a very good idea of what their specific pain triggers are. Yeah. So I hope I didn't get too off topic there on you.
No, gosh, no. I love that you're giving us some nice full answers. Just as a personal example, I'm sure a lot of people can relate to this. I was 29 and starting to age out of my dance career, and I had a tremendous amount of pain. And the orthopedic surgeon that I saw said, well, come back to me when you're ready for surgery. And I said, how will I know? He said, you'll know. 10 years later, I couldn't use my right leg. So and then I did actually end up having a discectomy. So how often do you think with proper care I mean, obviously, maybe it's not obvious. There's a lot of people out there that have herniations that never need surgery, never have pain. So how often when you have someone that had a condition like mine where there's a lot of radiating symptoms, do we actually need surgery, or could we maybe care for them? Or could good care have taken care of the problem? Proper
I
care.
know, I know exactly, Karina, because I'm the only clinician that I know of that's measured it. We measured and followed up with every single patient we saw over my full career at the university. I know exactly the score. So of the patients who they typically say, well, I've tried everything. I've tried chiropractic, physical therapy, yoga and Pilates. I've been to the shrink and I've had my orthopedic consult, and apparently I've failed it all. And the only thing left for me is surgery. When they came to the clinic with that background, we got 95% of them to avoid surgery, and they were happy for it.
Oh, fantastic. Yeah, I think.
So I can give you that statistic. And it really comes from understanding what is the mechanism of their pain. Now, again, a disc bulge, that's a very generic term. There's subcategories of disc bulges. We know that if the person has 70% of their disc height remaining or more, that usually a directional therapy, sometimes combined with motion and traction, sometimes not, but we can really vacuum in the disc bulge. If it's walled off and plugged, we don't. But then to perhaps in that individual, we might try some nerve flossing and getting the nerve to floss by the impinged area that is compromised with the disc bulge. That works quite often as well. But you have to sow the seeds. You just can't say to the person, well, do nerve flossing. We might say, lay on your tummy for 5 minutes. That helps to decompress the hydraulic effort on the posterior bulge. And then we'll try 10 repetitions of nerve flossing and go on from there. But anyway, there's the statistic to answer the question with a little bit of a thought on how we might go about achieving that 19 out of 20 people.
Yeah,
Don't need.
that's great. That's great to know.
I wish I saw you 20 years ago.
Did you say that again? The what?
I said, I wish I saw you 20 years ago.
Yeah, me too. Me too. I I do tell people that see me now that they when they ask my thought on surgery, you know, when I went in to see the surgeon, I was barely walking, and I had been barely walking for quite a while. And he gave me a time limit. You know, there was a time limit on how long I could go without having surgery before these symptoms were permanent, and I would be dragging my leg behind me the rest of my life. Is that how that scenario generally goes? If that right leg or left leg isn't working due to symptoms in the spine, that it's just never going to come back unless we get that pressure off of the nerve? How does that go?
Well, there are cases where that is true, there's no question. But there are many cases where it's very false.
Okay.
So it's on a case by case basis. But we will know fairly quickly if the person is going to respond or not. We use the principles of what we call spine hygiene. We define the mechanical driver of the disc bulge, if that's what we're talking about, if that's the target for the knife in the surgeon's hands, if it's a disc bulge. We will try to decompress the disc bulge by stopping the offense, whether it's directionally driven hydraulic pressure in the nucleus, whether the annulus has been, excuse me, delaminated, or whatever it is. And then we coach them to move in a way that stops that mechanism of spine hygiene. And for example, I can get out of the chair. If I had a posterior disc bulge, I can flex forward and get out of the chair. Well, I just pressurized the posterior disc bulge. But if I did the opposite, if I sniffed some air first, and now I lean forward through the hips, I just completely eliminated the offense.
Mhm.
I don't know if you can see here, but on my shelf in the clinic, I have
Mhm.
many, many different models of different mechanisms of pain. So the one I just described, and this might not be too unfamiliar to you, can you see the little red deformation at the end of my finger? Now,
Yes.
just watch. I'm going to flex forward and squeeze. Do you see the nuclear material being driven posteriorly because of the hydraulic effort is posterior? It's squeezed and flexed. But
Yeah.
now I'm going to stack the spine tall and I'm going to squeeze. But do you see when I squeeze, nothing comes out of
Ah.
the laminated collagen and it's pure hydraulics.
Oh, okay.
You see, if I want to squeeze an orange seed that way, I bias the pressure and it goes out that way every time. So that's what posture does. So again, this idea that posture doesn't matter, it's causing a lot of grief for people who have very specific types of posturally driven mechanisms. So that would be one of them.
Yeah.
But that delamination that I showed you, if you stop creating the hydraulic pressure and separating the collagen fibers, it will gristle. And then over time, you build resilience. So there's, I think I have Olympians in just about every Olympic endeavor, people active in all of the big professional sports with quite interesting and large disc bulges. They
Mhm.
were able to uh, A, reduce the bulge, B, reduce the pain sensitization and regain their athleticism sufficient to compete.
Yeah.
Now, are they absolutely bulletproof? No, they do have to manage it, but if they are skilled and well coached, most of them are able to manage these challenges to subclinical levels. So they're
Mhm.
winning medals, many millions of dollars in salary, and all the rest of
Yeah.
it.
Yeah. So is that part of ongoing lifestyle for these people that you work with? Does there come a time when those of us with back pain, your patients with back pain, they just go on their normal life, or is it always going to be there's a regimen for your back pain, or there's a regimen for not returning to that type of pain?
Well, let me ask you two questions. So you're a former athlete as a professional dancer. Do you know of a professional dancer who is not managing something? Are
I
all of them perfectly healthy?
I do not.
Okay, I do not know of a professional athlete who isn't managing something. So there's the answer. The ones who are successful at life are the ones who are the successful manager of stress, be it psychological, be it physical, and allow that stress to build your body rather than crossing the tipping point so it tears you down. It's an optimal function. You've got to stay on the proper side of the tipping point.
Tipping point.
So anybody can cross the tipping point by being either irresponsible, ill-informed, or unskilled.
Okay. Yeah.
Okay, so I hope that answers the
Yeah.
question. I would love to go and do crazy things and have all the athleticism I had in my 20s.
Yeah.
The reality of it is, if I did that, I'd be crippled and
Yeah.
everyone else would be as well.
Yeah.
So, but our job is to know how to expand the area and the capacity under that tipping point. So now the person gets to play pickup basketball with their grandchildren. They get back on the golf course. They get to ride their bike and swim and really have fun with life. And that's the key to it all. But can they go back and go crazy? No one can. There's always a biological limit.
There's a biological limit, yes.
Yeah.
If we switch gears a bit, our group does specialize Scolio-Pilates and scoliosis-specific exercise. And that was founded out of, again, my own spine. Having had surgery, I didn't know I had scoliosis. And the spine surgeon said, "Oh, by the way, you have scoliosis." I said, "Well, doesn't everybody?" He wrote in my chart, "Irritable." And so after the surgery, I did get some use of my leg back, well, quite a bit of use of my leg back, but the scoliosis destabilized, it got worse, and so hence we created this exercise form. And as we go through and I look at the muscles, they just don't function the way that we would expect a muscle to function. And there's so many studies out there that state that, you know, this muscle is doing this and this muscle is weak, this muscle is strong, or this one's activating, this one's not activating. However, I've had the privilege to do just a couple of scoliosis dissections, and it doesn't appear that the muscles are, in terms of texture, terribly different. Is it possible that the muscles are just serving a different stabilizing type of function and just not doing what we expect them to do physiologically due to the rotations?
It's a fabulous question. I know exactly where you're coming from. I strongly suspect that that's the case, as you've just stated it. But now we have to get into a discussion of what's cause and what's effect. Was
Mm-hmm.
there something unusual about the muscles that promoted a odd deviation resulting in scoliosis, or have the muscles now responded to something else? So I'll let the world know that I have scoliosis as well. It's a bit developmental, but perhaps not. I had a hockey stick go through my rib cage when I was a younger fellow, and my ribs are now fused on this side. So when I'm teaching a course on assessment, I'll have someone put their fingers interdigitating into my intercostal muscles, and then I'll breathe. And then what they will notice is this rib cage is elastic and it expands. Hence, this lung has much more capacity for expansion and contraction. But this rib cage, through these ribs through here, it doesn't really work anymore. So what I've developed, and the more I breathe, I get more scoliosis.
Yeah.
So that's a developmental scoliosis. And then I'll get another patient who comes in with scoliosis, and they have the same apparent breathing mechanism where one rib cage is really opening up with bucket handle dynamics and the other isn't. And there's no trauma. Look at their x-ray, and their heart is biased on the other side. And for some reason, God just put their heart on a different side. So the lungs are not normal. So when they breathe, they've got a baby lung and a larger lung. Who knows what caused that? Maybe it was just that's the way they were made from birth. So their rib cage has developed as they went through challenged breathing, and it built a curve.
Mm-hmm. Yeah.
What was cause and effect there? It becomes such an interesting discussion. But then my world isn't, groups of back pained people. It's always a single person. So we'll bring in that single person and try and understand their mechanics. I'm sure that the muscles change. So not only do the muscles change their vector direction, so consider my external oblique. My external oblique causes left axial rotation, it causes right lateral bend, and it causes flexion. So it has action about all of those three axes. Well, if I develop quite severe scoliosis, I've changed that vector direction. But the second part that people don't talk about very often is the length tension curve. So when we take a muscle like a bicep, which crosses my shoulder and my elbow, I have an ability to create maximum force about there. But
Mm-hmm.
if I change my shoulder, I've shortened the muscle, the strength curve actually increases at a bigger elbow angle, if you know what I mean. So muscles produce force as a function of length. Well, you really change and modulate that force length relationship in a deviated spine. So we don't know anymore, not only is it vector direction, but the force potential has changed. Muscles are elastic. They don't have to be neurally driven through nerve signals to create force if they're stretched. So these are the fantastic dynamics that make scoliosis so interesting in a case-by-case study. But I think the seminal question for you and for me is, are we able to change it? Can we possibly help these people? So what we do is we hang them from a bar. And if their scoliosis straightens, we'll say, you know, mechanically, you have the ability to straighten, and that really is the green light for us. Let's try some Schroth. So you were talking about silly stretches. Well, they're not silly anymore if they are addressing the tension balance that you're talking about. Can we stretch those on the convex side? Can we add a bit more stiffness or turgidity on the ones on the outside of the curve? And can we help them? Well, again, I told you we follow up with people. I'm thinking of one professional defensive halfback in football. And his deviation was growing. He was able to reverse it through strategic stretching and strengthening and creating that balance. As you know, sometimes is it a leg length issue? Is it an imbalance in the psoas that is causing a rotation in the pelvis? Or is it a foot falling into inversion, and driving the knee into valgus, pinching the hip and internal rotation, twisting the pelvis? I mean, we live in a linkage. So some of these things are really interesting to try and figure out. Anyway, there's a beginning of that particular discussion. Can I just give you one more thing to finish off that whole discussion? When I think of the people who come and ask for my consult on scoliosis, and I admitted right out at the beginning, I'm not the expert in scoliosis. However, they have back pain, and that's where my expertise does lie. There's two times in a person's lifespan when I think people like myself and perhaps you really have a chance to modify this. And one is during adolescence, during the growth phase. And the second time is the person is now retired, and either they're going to lose their fitness, their occupational fitness, or they're going to regain their fitness. So their job, they were a desk jockey, now they want to ride their bike and really, I'm fitter now that I've retired because I get a chance to work at it than when I was a slave to the desk as a professor. I think of one patient that I saw not too long ago. You're not going to believe this, but he was a surgeon. He came to see me with his back pain. And his real love now, he would hump over the operating table doing complicated spine surgery for 2 or 3 hours. That built tremendous endurance. He had occupational fitness in his back. He quit that. He lost his stiffness and muscle strength in his back, but the scoliosis really started to develop now because he became weak. And as he breathed through that dominant lung, and the scoliosis just took off.
Yeah.
So it was so important for him now. We had to restore first and foremost back fitness.
Yeah.
And then he was able to build capacity to ride without this huge asymmetry.
Yeah.
But anyway, do you find that where the second time we have to be vigilant for scoliosis is post retirement?
Well, we deal with so many women because while men and males and females have scoliosis at an equal rate, women are much more likely to progress. And so for women who we see most of the time, it's going to be adolescence, pregnancy, and menopause. So menopause is a bit before retirement, but yes, those are the three times in a woman's life that we have to be very vigilant of what's happening with the scoliosis. Um, but with men, yes, they'll be closer to retirement, and whether menopause and andropause, men andropause will come closer to retirement. Women menopause is before retirement, so it's a bit of a toss up. But I love your point that I could potentially be more fit once I retire because I am finding myself being a bit of a screen addict these days. And I had that app on, or I had that capacity on my phone to tell me how many hours I was on the screen between my computer and my phone. I had to turn it off. It was too depressing. It's just like I thought I was super active, walking the dog and riding my bike. And then it's still telling me that I'm at my screen 8 hours a day. And I thought, no, this can't possibly be true. And of course it is. But yeah, so the vigilance.
Karina, I hate to admit this. People said, "Oh, why are you retiring? We need you," and that kind of thing from the university. And I said, "For my health."
Yeah.
When I first started at the university, people don't realize this. Personal computers weren't invented yet. You typed your thesis on a typewriter,
Mhm.
and we wrote letters by hand. But students came to office hours. We were walking around. It was a very dynamic job. Then, with the advent of the personal computer, we became a slave to that. And then students even wanted to say, "Well, can I just email you?" And I said, "No, I come to office hours. Get moving. Get off the screen." And then the university encouraged it with online this and that. Anyway, I got to the point where I was becoming so unhealthy being a slave to the computer because of my job. I said, this isn't worth it anymore. And now the first thing I do, I get out of bed in the morning and I go for a walk with my dog. What a great way to start the day. And then, I might do an hour's worth of computing and then I go and do something else. And I might see a patient. And do you know what I mean? It's
Yeah.
lovely to restore that physical balance back into my life. And I have no pain now. I feel fabulous. But I had pain when I was a professor.
Yeah. Yeah. Sometimes it's hard to take the time to follow your own advice. I've certainly experienced that.
Yeah, well, don't leave it too late. A very wise professor, in fact, it was the professor who started our department, a fellow named Norm Ashton. He said, "My one advice to you," and this is when I was first hired at the university, he says, "Don't stay until you get sick."
Oh, yeah, I like that.
And I thought about that. And, I've outlived my father now. And but I absolutely feel fabulous. And honestly, I don't miss the university and the computer one little bit.
Yeah, yeah, and I see you do have quite a travel schedule as well. You were in Australia recently, and I see your next workshop is in Canada, but after that, you're heading overseas again?
Yeah, I'm really winding down my travel, and
Mhm.
it's that there's just more to life now. I enjoy seeing patients here,
Good.
and we have a little uh, master clinician mentorship that we do here.
Well, fantastic.
Pardon?
That sounds fantastic.
Yeah, so I'm not so keen. I spent 30 years on the road once a month. Traveling somewhere. That was my uh, the limit I used to put on myself. Anyway,
Yeah. So, your one of your books is The Gift of Injury. What made you want to finish up? Won't keep you forever. Um, what made you write that, and what is the gift of injury?
There was a world champion powerlifter named Brian Carroll. He'd set world records in two different weight categories for squatting loads. So they put a barbell on their back, they squat to a depth and lift it up. And he was lifting close to 1,200 pounds, if you can wrap your head around that kind of number.
Not really. Can't even fathom.
Yeah, it's incredible to see. And I saw a document not too long ago, but in the world of powerlifting and all-time numbers of meets that you've attended and the scores that you put up, he was ranked number 2 of all time in this multiply powerlifting. But anyway, he called me up, and I think it was 2015, and he said, Professor, could I come and see you with my back? And I'd seen quite a few power lifters. But when he came to see me, it was really quite horrific. He'd split his sacrum, big fracture, front to back. The L5 and the L4 discs were really, if I used the words obliterated, that wouldn't be too far off the mark because we show the MRs in the book. But long story short, I said, well, I think I can get you out of back pain. And here's my opinion, go execute it. But he said something very curious at that time. He said, oh, well, when I'm out of pain, can you help me get back to being competitive again? I want my world record back. Someone had just stolen it while he was injured. And I said to him, well, honestly, if you were my son, I would advise you to retire. This is a massive injury. And I'd be thankful just to get out of pain and enjoy good life. He said, no, I think I want my record back. And I said, well, if you can get out of pain and you can recover well enough to squat almost 1,200 pounds again, we can write a book on that. So now you know the story. He did come back, and he won the Arnold's 2 years later and the year after that.
Wow.
And he said, okay, you said we could write a book together. And that became, now that title had a lot of thought to it. It was actually a gift because it did a lot of things in his life. It got him to appreciate real scientific training. There's no margin for error anymore. It's a discipline. You move well throughout the day to build a capacity to train pain-free. If you're sloppy in your movements throughout the day, you will never build that capacity to train to lift 1,200 pounds again. So that was the gift. It gave him the discipline and an understanding of the biological reality to use science to rebuild his body again. So that's why I said it was a gift. And it's, I'm sure many of your patients and certainly our patients would say that as well.
Yeah, I think so. It takes a while to get there, I think, but in the end, they can see where their lives have changed for the better. I've heard many people say things along the lines of, you know, if it weren't for my injury, I wouldn't have had to pare my life down to the essentials. And the essentials are where I want to spend my life anyway. So it's always nice to hear someone is spending either more time with their family or their kids or the things they're passionate about in their life, because while there is the scientific training to get back to where your athlete was, there's also the art of life, you know, to continue living better. And
there's some hard-won wisdom coming through. I was going for a drive, I guess it was Saturday on the weekend, and I drove by a billboard on this highway from a real estate agent, and it had 7 words on it, and it really stopped me in my thought tracks. Work hard, be kind, that is all.
Oh.
Now think of that, 7 words.
Mm-hmm.
The Beatles said all you need is love, and I've thought about that so much in my mind. Yes, love the earth, love animals, love people, I get all of that. However, it isn't complete. But then when you said work hard, feed your soul,
Mhm.
have a purpose in life. Now add be kind. And that
Mhm.
is all. And that was the missing element for me. So I think that's part of the art of life that you're talking about.
I love that. I love that. If you have something like you have, like I have, that you can be passionate about in your life, it is a gift. It is amazing. I want to thank you so much for your time, Dr. McGill. You spent almost an hour, maybe more. I've been watching the clock. Okay, a little more. So grateful that you're able to spend this time with us. And I do want to remind people that you can find Dr. McGill at backfitpro.com, where you'll find his books, you'll find his seminars, and I guess they could also find a way of reaching out to you personally through the website. It's probably how I found you. I'm not sure anymore, but
Yeah,
yeah.
um, yeah, I'd rather say a email to an assistant for sure.
Okay.
Yes. Yeah.
Yes. Excellent. Well, thank you, and we wish you the best in the your upcoming workshops and mentorships and travels, and hopefully we'll hear from you again sometime soon.
And thanks very much for all that you do in
Okay.
spreading the word and providing the leadership that you do. And you're very good at podcasting. You've got a great team.
Thank you very much.